So this is part 2 of the PowerPoint for kidney disease, and at this point we're focusing on chronic kidney disease. So you notice that in the very first bullet here, they're describing chronic kidney disease as a progressive, irreversible loss of kidney function, and that is the most important difference between AKI versus CKD. The fact that when we're talking about CKD, we're now talking about irreversible loss of kidney function. So more than 26 million Americans apparently have CKD, and it is definitely more common than AKI. Some of the reasons why our population is getting a lot of people with CKD has to do with the fact that people are aging, there's increased rates of obesity, there's increased diabetes and hypertension. And as you were doing your reading, I'm sure you saw that diabetes and hypertension were like the biggest culprits for CKD. So unfortunately, over 500,000 Americans are receiving treatment for end-stage renal disease, and they also have a high mortality rate. So once you start needing hemodialysis and those types of treatments, that's long-term, right? Unless you are lucky enough to even get a transplant, and that's a whole other different story with that. So this kidney disease improving global outcomes group apparently defines CKD as the presence of kidney damage. They are basically seeing some pathologic abnormalities, and they know that there's a problem. Once they're doing a whole bunch of different markers, so they're looking at the kidneys, they're looking at they're drawing some blood, looking at the urine, seeing how well the GFR is, those types of things. So here we've been given the number of in order to qualify someone as having CKD, chronic kidney disease, that their GFR is less than 60 milliliters per minute, and it's been at that place for at least longer than 3 months. All right. So once again, I need you guys to let me know what the regular GFR should be for a normal person. So there's so many different causes for CKD. So you can see here that diabetes is up at 50%. So that is really, really sad, because if somebody has, in particular, like type 2 diabetes, that is something that we can really prevent in some ways, depending on our diet and our lifestyle. So we're seeing diabetes at 50%, and we're seeing hypertension at 25%. And hypertension, for sure, we can do something about, right? Some of the other less common causes for CKD include things like glomerulonephritis, cystic diseases, where sometimes the patients develop cysts on their kidneys, and any other types of urologic diseases that might place the patient for having CKD. Apparently, even though the patients have CKD, apparently even 70% of them may be unaware that they actually have CKD, and that is because the kidneys actually, or the body, is very, very adaptable, right? So you really don't see any big problems until a lot of the nephrons have been destroyed in the kidney. So with that, then that means that at least a lot of these patients become untreated and underdiagnosed. So then by the time we catch it, it's late, and then the treatment has to be that much more aggressive. These are the stages of chronic kidney disease. For your purposes, once again, I would like you to at least know what stage 1 looks like, right? So that would be considered maybe a risk at this point. And then what stage 5 is looking like here, right? And I don't need you to memorize any of this at all. And remember, I think in the AKI, I'd mentioned that when their GFR is less than 15 milliliters per minute, that's when we're categorizing the patient as being in end-stage kidney disease. So therefore, at that point, they are going to need some type of renal replacement therapy. So just know that this is out there, and we'll talk about this in class as well. So I don't really need you to memorize any of this at all. So good news, Medicare covers about 80% of the costs. It is considered a disability. I would like you guys to discuss with me why we're seeing an increased incidence with Blacks, Native Americans, and Hispanics. Why are these particular populations more susceptible to CKD? All right, so we can talk about that. So once the kidneys are failing, progressively failing, to the point where they are irreversible, you are going to see just a disturbance in basically elimination of waste. That's the biggest thing. So all of the manifestations that you're going to see in the body have to do with the fact that the kidneys are not doing their jobs, right? So you guys will once again remind me what it is that the kidneys are supposed to be doing. They're supposed to be regulating water, balance, eliminating waste, producing erythropoietin, turning vitamin D to an active form, like all these amazing things, right, that they're supposed to be doing. So if they're not doing that, then what are we seeing in the patient? So that's essentially what all of our clinical manifestations are going to be about. So I'm not even going to like spend way too much time on each of these slides for the clinical manifestations. I'll probably just highlight some of the bigger ones, but I think a lot of the clinical manifestations are actually pretty self-explanatory. And for your purposes, just think that the body is toxic. It's a toxic environment. There's uremia. Red blood cells are being created in some cases just a little bit, but then they're also dying very quickly because the environment is toxic. So think of the body being just dirty, like extremely dirty. So how would that affect every single organ in your body, right? What would that look like? So nothing is working like it should be. And some of the charts that they have about the systemic manifestations are very similar to some of the other conditions we've talked about. So like under neuro, you are seeing particular disturbances. Under liver cirrhosis, you are seeing, particular disturbances. So it's the same thing, right? My environment is toxic, my kidneys are supposed to be doing something, and that is no longer happening. Okay. So now you are seeing things like uremia, and primarily this is when the GFR is less than or equal to 15 milliliters per minute. So this can be exacerbated in some patients, maybe because they're older, maybe they have other comorbidities, and maybe they're not even adhering to medical management, right? So this will look different in everybody, but the end result is you're uremic, you're toxic. So this is the slide I was talking about in terms of your clinical manifestations. So you are going to spend some time looking at this chart because you know how much I like charts. So you should be able to tell me if I ask you what are some of the neurological manifestations that you might see in a patient with CKD. You should be able to tell me that. If I say, well, the bigger ones actually, let me help you out a little bit. So it's things like the cardiovascular system, GI, the hematologic, that can be really, really bad, musculoskeletal, skin, and pulmonary. Those are like some of the bigger ones that you should probably, kind of think that I might ask you about, right? But I mean, no, like look at each thing in here because I still want you to be familiar with everything. But once the kidneys have been implicated like this, you see how everything is circular, right? So everything gets affected. And I think you can understand why this is going on. Okay. So we'll just briefly go through some of the changes that happen in CKD. So in the early stages, there's no change in the urinary output, obviously, because the kidneys are still trying to adapt. But as the CKD progresses, then you're getting things like increased fluid retention, and the patient may even need things like diuretics, and after a while they may end up needing dialysis, right? And some patients may become completely anuric. You're getting the waste product accumulation that I mentioned. So GFR is decreased, BUN and serum creatinine levels are increased. And so remember we've talked about the BUN and how there's so many other different things that can cause a BUN to increase. But here specifically under CKD now because they have the kidney failure. That is the main reason why you're seeing this BUN level increasing. So there's a whole bunch of even maybe muscle breakdown happening. Maybe the patient is also still eating protein, and they're not even aware that their kidneys are failing, right? So maybe they're on steroids, they have a temperature. All of those different things can be reasons why. So you're going to be seeing like some of these manifestations of that. So things like nausea, vomiting, the patient's lethargic, they're fatigued, they're getting like impaired thought processes, and headaches happening. All of that is happening in the patient. So remember I said in order for you to see whether or not there's kidney damage, we focus on the creatinine, right? So the creatinine is a better indicator that something is wrong with the kidneys. But when we're talking about CKD specifically, we're really concerned about the GFR. So we are looking at the calculated GFR. That is the most accurate indicator in terms of us figuring out whether or not the patient has chronic kidney disease or end-stage kidney disease, where now they're definitely, the GFR is incredibly decreased. Some of the other clinical manifestations, so you can have what is known as impaired glucose metabolism. So at this point now, the insulin is not doing its job. Also, the insulin is not being excreted by the kidneys. So you may be seeing things like hyperglycemia and hyperinsulinemia. There's defective carbohydrate metabolism. So you just have to be careful if the patient is a diabetic. So insulin dosing must be individualized, and hopefully you hope that it gets better after dialysis. And really with CKD, it's all individualized in terms of the care. You're probably going to get sick of me saying that. Diet is individualized. Medication administration is individualized because you have to look at all the stages to see what would work best for the patient. Okay. The hyperinsulinemia stimulates hepatic production of triglycerides. So you're getting things like altered lipid metabolism. They have decreased levels of enzyme lipoprotein lipase. So there's no breakdown of the lipoproteins. So essentially with that, you're getting decreased HDLs. One of the biggest issues with the patient having the triglycerides here is that they can potentially die from cardiovascular disease. Okay. Potassium is really self-explanatory. I think you guys know why the patient is ending up with too much potassium, right? So some of it is decreased excretion, breakdown of cellular protein, bleeding, things like metabolic acidosis. Maybe the patient is still not eating very well, right? So all of these things could be the reasons why the patient is getting the hyperkalemia. But now I need you to pay attention to the levels. See how elevated this level is. So it's anywhere from 7 to 8. And what is my normal potassium level? What should this number actually be in a normal person? Okay. Sodium, self-explanatory as well, right? So depending on when you're drawing the blood, once again, if there's a lot of fluid retention, the patient can potentially have dilutional hyponatremia. And when you're measuring it, then the sodium level may actually look like it's low, but it's just because of all the edema that's there, that's happening with the patient. So then the patient's going to show up with things like edema, hypertension, or heart failure, and those are the reasons why their levels of sodium are going to be altered as well. Okay. With the calcium and phosphate, so you're not getting the activated form of vitamin D, you're not getting calcium absorption from the GI, you have low calcium levels. You get PTH being activated, then you're getting bone demineralization happening because now you're releasing calcium from your bones, right? Then the phosphorus also is released. So the PTH is releasing calcium from bones, but you're also releasing phosphorus. So you're getting these high phosphorus levels. And also you're getting high phos levels because the kidneys are also not excreting phosphorus, right? So this is really just a bad situation in terms of the calcium and the phosphorus here, right? Other things you may see are things like hypermagnesemia. I don't think I spelled that right. Wait, hypermagnesemia. Maybe I did spell it right. So they're supposed to be, magnesium is supposed to be excreted by the kidneys, and that's not happening as well. And maybe your patient is also taking some other things like milk of magnesia, magnesium citrate, or antacids, right? So then you're going to be seeing all these weird manifestations. So you guys have done fluid and electrolyte imbalances, right? And I expect you to know how to interpret an ABG, okay? I'm expecting you to know how somebody that has hyperkalemia may present, how somebody that may have hypocalcemia may look like. So all of that is considered previous knowledge. We'll talk about it again, just remind me, but I'm not re-lecturing any of that, but I need you to be able to know how to read like an ABG, right? So we'll talk about that. Yeah. And so they also end up with things like metabolic acidosis. So at this point, I'm just going through these very quickly because the kidneys are basically unable to excrete excess acid, right? And there's a defective reabsorption and regeneration of bicarb, all right? Anemia, decreased production of erythropoietin happening. There's decreased iron stores. There's potentially also folic acid that's being lost in dialysis, right? The RBCs that they do have a very short lifespan, exactly because of the toxic environment that the RBCs are in. All right. Some of the RBCs potentially can even be lost during even during dialysis as well, right? Some patients end up having complications from that, and maybe they're also having things like GI bleeding. So all of this is possible. Okay. So bleeding tendencies, there's defects in platelet functioning as well, infections, there's changes in the WBC functions, all because of the environment. Under cardiovascular diseases, some of the main reasons why somebody may die has to do with the patient getting things like MIs, PADs, heart failures, and even strokes, right? And for the CV risk factors, it's always, things like hypertension and elevated lipids. So none of this should be new for any of you. Okay. And hypertension, you know that it's a cause and it's also a consequence of CKD, and pretty much because of the sodium and water retention that's going on. So with the hypertension now, you can get weird things like retinopathies happening, encephalopathies happening, nephropathies happening. It all depends on how elevated this blood pressure is, right? So the hypertension, we really, really monitor hypertension in our patients with CKD. That is like the biggest problem. It's all about sodium and water retention, and making sure that we are cleaning the patient's environment so that they can, they can function. I don't know if I told you this already, but I had a colleague that was a surgeon actually at Beth Israel, and he was on hemodialysis, and you could tell when he needed to get dialyzed because he would get really, really moody. He would get like he would be short. Like it actually affected him and his interactions with people. So yeah, because think about it, how many times in a day do you get up and use a bathroom, right? Think of all the things that the kidneys do for you. Like how many times a day do you get up, use a bathroom, and just go about your day, right? And now think about the person that the kidneys are not working properly and all this waste is building up in their body. They're not going to feel good, right? So for him, it definitely, there was some like kind of neurological almost type of manifestations. And he was a very pleasant guy, but I think he got dialyzed like 3 times a week, and it's just something that he lived with, right? So that was like my actual experience with somebody who was getting hemodialysis on a regular basis and was also coming to work every day and doing everything that needed to be done. Okay, so I already mentioned BP control as being a big one. We're worried about dysrhythmias, obviously, from the hyperkalemia, right? And look at all these cardiac manifestations that can happen. So some of these we mentioned already under AKI. So because of the toxic environment, once again, metabolic acidosis, the fact that the patient can have things that cause more respirations. Every part of the GI system is affected, and the cause is the excessive urea, right? So you're seeing these nice words like stomatitis, you're seeing this uremic fetor, urinous odor of the breath, things like anorexia, nausea, vomiting, are pretty much GI types of things, right? Diabetic gastroparesis, GI bleeding, and constipation. So all these things are going on. And neurologic changes, yeah. So like I mentioned, with my colleague, you could kind of see some changes happening with him because the environment is incredibly toxic, right? So patients can be lethargic, fatigued, irritable. This was definitely true for him. I didn't see like an altered mental ability, no, but he definitely was irritable, and that's really how it just showed up with him primarily. Brilliant person. So some of the later manifestations: seizures, coma, and hypertensive encephalopathy. Okay. Other neurological types of things: restless leg syndrome, paresthesias, some motor stuff, so foot drop happening, muscle weakness and atrophy, loss of deep tendon reflexes, and all these other weird things that are going on. So remember Asterix? What does that look like? Okay. So with the CKD mineral and bone disorder, so with this one, you're getting complications like osteomalacia, and you're getting things like vascular calcifications that can happen as well. So let's just look for this one. We'll just look at the chart. So here you're seeing that the patient has kidney failure. So there's a decreased GFR. We're focusing on this side over here. So decreased activation of vitamin D, impaired calcium absorption from the gut, decreased serum Ca. You're seeing this increase in PTH. So with that, you're getting all these weird things like osteitis fibrosa, osteomalacia, which is a bone demineralization that's going on. And then here you're getting the vascular and soft tissue calcifications that can potentially happen. All right, so this is why you're getting some of the bone types of disorders that are happening. Okay, itchy skin for sure. So I forget which condition we talked about where the patients were really itchy. Can't remember. It must have been liver cirrhosis. So here under CKD, you're seeing things like uremic frost, and this is basically just the urea crystallizing in the skin. It is a rare condition, but it definitely can happen. Okay. Reproductive, so things like infertility and decreased libido. Both sexes, low sperm counts, amenorrhea can happen. So obviously low sperm counts is for the males, right? But both sexes can experience things like, for sure, like decreased libido here. All right. So personality and behavior changes, emotional, labile. Patient may be withdrawn. So things like anxiety, depression, and grief. So I really would like to hear from you guys if you either have family members or if you have taken care of patients who needed hemodialysis or were in chronic kidney disease stages. Okay. So diagnostic tests, any of these are possible. You are going to focus on the ones that I asked you to look at, and you can tell me all about them. Okay. So we want to preserve existing kidney function, reduce the risks of CV disease, prevent complications, and make the patient as comfortable as we possibly can, right? We want to treat them and, reverse anything if we can. But, by the time we get into CKD, our time is running out. Okay. So biggest word for you is that the management is individualized. You are going to look how your patient presents. Do they have things like anemia issues? Is it fluid overload or deficit? Like, what is going on? Is it a nutrition problem primarily for your patient? Is it the bone disease types of issues. Is it hypertension? All of that. And we need to figure out, okay, what do we need to do for our patient? Okay. So for hyperkalemia, once again, you guys know this. I would like you guys to explain to me how the glucose and the insulin help the hyperkalemia. All right. You're familiar with these medications like Kayexalate. You may not be too familiar with Patiromer. So apparently this binds potassium in the GI tract. It also may bind to other oral meds. So they want you to take it 6 hours before, 6 hours after those meds. And apparently it has a delayed onset. Go to still for hyperkalemia. If it's really, really elevated, we're worried that the patient's going to die, then dialysis, is fine. So hypertension, we'll try meds, but diet is also helpful for these patients for sure. So you guys can remind me once again what a DASH diet is. Okay. So some of the mineral and bone disease disorders, so we're going to see, okay, what are the minerals that are involved. So if it's too much phosphorus, then we want to make sure that we're getting rid of that phosphate. So we're giving the patient phosphate binders. Biggest side effect from that is that the patient can get things like constipation. And so even though you're given particular ranges, so whether it's phosphate or whether it's sodium or potassium, or sorry, whether it's phosphate, sodium, or protein, still you're going to monitor the patient and see like what makes sense. Across the board though, for sure, like sodium is pretty much restricted for everybody. They're not going to say that protein is necessarily restricted for everyone, but so that definitely is going to be patient specific and depending on how the patient is manifesting. But certain things, yeah, like potassium, that's dangerous, right? So we want to make sure that we're not giving them too much of that, or make sure they're not eating foods that's going to exacerbate the situation. So potassium is deadly, sodium is deadly, right? Phosphorus, if they have too much of that also, can be a problem. So then we may end up giving the patient, the phosphate binders. So here you just have some examples of that. This Renagel is helpful for lowering cholesterol and LDL levels. For the anemia, so we're going to be giving things like Epogen and Procrit. So these are usually when we're on the floor, we're giving them subcutaneously, right? But can also be given IV. Right, so apparently in at least 2 to 3 weeks, you're going to see some benefit from the patient getting the erythropoietin. Some of the side effects, unfortunately, are things like thromboembolism and hypertension. If your patient is presenting with things like anemia, you are going to do things like giving them iron supplements, maybe even giving them folic acid supplements, which are helpful for RBC formation. You avoid giving too many blood transfusions unless absolutely necessary, apparently because the patient can actually develop antibodies because they're getting repeated blood transfusions. So that can end up being a problem as well, especially if they're not getting their own blood, of course, right? So the patient with CKD is not going to have the cleanest, healthy blood. So they're not going to be getting their own blood. So they'll be getting somebody else's blood. So that's the reason why they may be forming these antibodies with repeated exposure. So yeah, so iron supplementation, some of the side effects are things like gastric irritation and for sure constipation. I'm pretty sure all of you know that iron makes the stool dark. So if your patient says, hey, my stool is black or whatever, that you let them know that that's perfectly normal, right? That's an expected finding. Some of the red blood cells are lost during dialysis. And I'll talk about dialysis in the next PowerPoint. So, because the blood exchange is happening with the dialysate, right? Sometimes some blood is even left back in the machine. So that's why folic acid is beneficial, because then you can get more RBC formation. If the patient has dyslipidemia, obviously they're at risk for CV disease. So these are all the potential medications that they can be put on. So things like statins, these are effective for lowering LDL levels, things like Lipitor, And then these other ones, fibrates, they're helpful for lowering triglycerides and increasing HDLs. So we're giving medications sparingly, and especially if the patient is on any of these meds. So things like digoxin, diabetic agents, antibiotics, and opioid medications. Kidneys are not working, so we just have to adjust the doses. Your nutrition therapy is patient specific, and it's basically just to maintain good nutrition. As I mentioned earlier, protein can actually be very normal in terms of for stages 1 through 4, but they will adjust it as needed, because we do want the patient to, well, it's amino acids, right? And they're the ones that are going to help in healing. So we do want them to get some amount of protein. I know that the restrictions happen when patients definitely have high levels of things like sodium, or they have too much fluid retention. Those are the bigger things that they restrict, like really, really stringently. So there's fluid restriction with hemodialysis, and the intake depends on the daily urinary output. So you guys can let me know what that calculation looks like. Okay. So sodium, big deal. So for the nurse, it's all about making sure the patient knows what to eat and what not to eat. So nothing canned, right? Like throw that out the window. And then some of the salt substitutes apparently can contain potassium chloride, right? If the patient is on a potassium restriction, so limit 2 to 3 grams, and high potassium foods need to be avoided as well. So once again, that's going to vary for the patient. I'm not expecting you to remember the grams, or like how much per day, but I am expecting you to know that yes, there are sodium restrictions and there can be potassium restrictions, those types of things. So phosphate restrictions in some patients can be 1 gram per day, and making sure the patient is not getting a lot of foods with phosphate in them. So for CKD or for kidney disease, I do expect you to know which types of foods are okay versus which ones are not good, because this is important for lifestyle changes. Okay, so this is the easy stuff now. So we know what can cause it. So now we're going to do our nursing assessments, making sure the patient basically is eating properly, if they're on any nephrotoxic medications, what is the support system. We're looking at all of that. So potential nursing diagnosis, and you see how fluid imbalance is at the top, electrolyte imbalance, impaired nutrition, and difficult coping. So really, it's all about adherence to the plan, making sure the patient is involved, making sure they have effective coping strategies as well. So in terms of health promotion, identifying people at risk for CKD. So we already know which conditions are really implicated. So things like diabetes and things like hypertension, right? So making sure the patient's keeping their regular checkups, so that if we can catch this early on and they change their diet, potentially that we can reverse some of this. Okay. So a lot of this care can happen on an outpatient basis. Usually if the patient is in the hospital with CKD, it's primarily because of maybe there's complications or the patient's needing a kidney transplant, right? So part of the ambulatory care that we do in terms of teaching, so diet for sure, drugs for sure. So you're helping your patient have a pill organizer, teaching them which medications to avoid, especially over-the-counter types of meds, taking their daily BP. They have to be able to identify signs of fluid overload and things like electrolyte imbalances. Okay. And, if they need to, we can see whether or not they need a kidney transplant. But once again, it's a long list, and there's particular criteria as to whether or not somebody can qualify for a kidney transplant, right? For our nursing evaluation, we are happy if we are able to keep like fluid and electrolyte levels within normal range. The fact that the patient with CKD is maintaining their lifestyle, they have an acceptable weight. All of these are good things, right? Making sure that they are following whatever the the regimen is that they're supposed to be on. So all of that would be good for us in terms of nurses, because then we know that we're doing our job properly. So this is my effort, just to make everything as simple as possible for CKD. So this is, I think, the most important information for this part.